open it up for questions from reporters on the line. With that, I'll now turn it over to Commissioner Malcolm.
Thank you, Mike, and good morning, everyone. Thanks for joining us at this special time on what we think and hope will be the last call of the year. So thank you for being with us and helping to communicate this important news throughout this remarkable year in so many ways. On the worldwide and national levels, these numbers just continue to be pretty stunning, and it's important to note that today is actually the anniversary of the day on which this unusual infection in Wuhan, China, began to be talked about and visible to us here in the U.S. So it's a sober anniversary, to be sure. There are now over 82 million cases around the globe. This was an increase of almost 700,000 cases in a single day, with over 15,000 more deaths in that day. So the total cumulative mortality is now just under 1.8 million people around the world. Here in the U.S., we've now had more than 19.5 million cases, an increase of more than 200,000 again yesterday, with an additional 3,605 deaths in a single day. So our total is now over 338 deaths in the United States. I mention these numbers just again to reinforce that this is truly a national and global tragedy in loss of life and long-term health damage that we are just beginning to understand, as well, of course, as the immense disruption that this pandemic has had on every aspect of life. Here in Minnesota, we're reporting 2,019 cases today on yesterday's testing volume of just over 25,700. This brings us to a cumulative total of 413,107 laboratory confirmed cases since the start of the pandemic last March. There are, as of now, 926 people currently in Minnesota hospitals being treated for COVID-19. Of those, 207 are in intensive care. Cumulatively, there have been a total of 21,748 patients who have needed to be hospitalized for COVID care. 4,597 have needed intensive care. Another 66 COVID-19 deaths were reported yesterday for today's announcement, bringing us to a new total of 5,262 Minnesotans who've lost their lives to COVID-19 since the start of the pandemic. Yesterday's numbers included 26 deaths from the metropolitan area and 40 in greater Minnesota. The ages ranged from 39 years old to 101 years old. 43 of the 66 deaths occurred among residents of long-term care facilities. I'll mention briefly that we've also started sharing daily updates on our MDH website showing the number of vaccinations that have been administered in Minnesota. Today's update shows us about 38,000 doses of vaccine having been administered. That is actually data as of Saturday. We know that number will accelerate in the days and weeks to come. And in a moment, Chris Erzman will provide more details on this, as well as the bigger picture of vaccine distribution and administration. We're certainly happy to be ending this difficult 2020 with decreasing case counts in the last several weeks. Though they are still at high levels, as we've discussed on prior calls, our case growth is down a full 68% from the peak in mid-November. The pace of the decline has slowed a bit in the last week, but it is still on the right path. We also see this reflected in lower numbers of hospital beds in use for COVID patients as well, compared to the hospital surge in November. It's about half the numbers of people who are currently in hospital for COVID. I do want to note that we've also seen lower testing numbers through December, leading up to the end of year holidays than we did before Thanksgiving. The state has worked very hard to make sure that Minnesotans can get tested when they need to. And we know that we have a lot more testing capacity around the state than is being used right now. And we hope Minnesotans will take advantage of the fact that there is a lot of testing capacity available, because having that information on whether people are positive helps not only us as individuals, but it helps our whole community reduce COVID-19 transmission even further when we know where the disease is and who has it, so that we can isolate and quarantine appropriately to stop the spread. That means we would have a slightly smaller forest fire to put out with that big fire hose of vaccines that we've been talking about in recent weeks. But certainly over the next month, we're going to be watching very closely for any upticks or any other notable changes in the patterns of our key metrics that we might expect to see over the holiday gatherings. But certainly, as we've talked about, the fact that there was no significant upsurge after the Thanksgiving holidays certainly is a testament to Minnesotans taking this very seriously and taking appropriate actions, and of course for the businesses that have suffered losses of business due to restrictions on gatherings. And with that, I'm going to turn it over to Chris Erzman for a vaccine update.
Thank you, Commissioner. As we mentioned last week, we have added vaccination data to our website. And what we added last week was vaccine distribution data and vaccine administration data. The vaccine distribution data reflects the vaccine doses that have been allocated to us from the federal government. We get vaccines sent to us once a week, and so we're updating that data weekly on Wednesdays at 11 a.m. Starting yesterday, the vaccine administration data will now be updated every weekday at 11 a.m. As a reminder, the vaccine distribution and vaccine administration data are not a direct comparison. The distribution data reflects doses allocated to the state of Minnesota from the federal government, but we know that there are other doses coming into the state through other federal allocations. The doses administered data is based on our immunization information system called the Minnesota Immunization Information Connection, or MIC for shorthand. We are reporting any COVID-19 vaccine doses reported to MIC, and some providers giving vaccine from those other federal allocations may report to us via MIC, and that will be included in our data. Registered providers getting vaccine from our state allocation are required to report doses administered to MIC within 24 hours. That's a little bit complicated, but the bottom line is that we're letting you know how many doses that we're getting as the state allocated from the federal government, and then we're letting you know how many doses have been administered by our partners reporting into MIC, and they may not be from the same allocation sources. Because doses are allocated by the federal government and are based on our population, we're not able to request more doses than what are being sent to us each week. There are a limited number of doses everywhere, so we're taking what comes to us and getting it to its final destination as quickly as possible. And I just want to let you know that receiving, preparing, and administering vaccines takes time. And the recent news from Wisconsin of a clinic needing to throw out 500 doses of vaccine due to a handling error that left them unrefrigerated for too long underscores the importance of proper training of vaccinators and staff and being thoughtful as we move forward with vaccination. We hear each week how many doses we're going to get, but then those doses have to be shipped to us, and that takes time. We don't have all of our doses in the state yet for this week's allocation. Then some doses are redistributed to another location from the primary provider that received the vaccine. Even once vaccine arrives at its final destination, there are processes that the sites need to follow to get things ready before giving vaccine. So vaccine is not just coming into the state and sitting. It's moving to where it needs to go, and then providers are administering it. And even after administering, there's a period of time before those doses get reported to MIC for us, to then be able to report out to you. So I think it's important to keep in mind that while the number of doses allocated and distributed in the state is very encouraging because it indicates what we have to be able to vaccinate, you shouldn't expect that the administration data will match that instantly because, as I said, it takes time for those doses to get to the state, to get to the right location, to have the administration process set up, and to get administered and reported back to us. So it's moving through the system as it's made available to us. So that is the vaccine. And right now, vaccination is happening in closed settings like hospitals and long-term care facilities. So it's not the same setup as when we have a large public flu vaccination clinic. This is a new vaccine with new processes that have to be put in place, and that adds some time to the process. I know it's tempting to ask why vaccination isn't happening faster, but actually, if you step back and think about it, vaccination is happening at an unprecedented pace. As the commissioner said, it was exactly 1 year ago today when our staff received the first notification of a cluster of unexplained pneumonia cases in a province in China through ProMed, a program of the International Society of Infectious Diseases. That was really the very beginning of the pandemic that has reshaped all of our lives in ways we could hardly imagine 12 months ago. And the fact that we even have a vaccine within a year of that first notification is remarkable. And the fact that we've vaccinated thousands of people in our state already is even more remarkable. Of course, we all want this to be over, and we all want more vaccine to be available right now. But I hope we can keep perspective on how far we've come and appreciate that vaccine is here in the state and people are receiving it. We are absolutely committed, as are our vaccination partners, to make sure that doses are distributed and administered in the most efficient way possible. And along with efficient distribution of vaccine, we're working to make sure that the limited doses of vaccine are distributed in a fair and equitable way. As we've talked about, we have guidance from the federal government for who should receive vaccine first, and then we have to take that guidance and apply it to Minnesota. Helping us do that is the Minnesota Vaccine Allocation Advisory Group. The group is made up of statewide representatives of leading care providers, bioethicists, state, local, and tribal public health representatives, healthcare associations, and people representing diverse community groups. The advisory group has met 3 times so far. They provided recommendations for Phase 1A priority group, which includes healthcare workers and long-term care residents. That was done in early December, and that guidance is posted on our website. The group will be meeting again this afternoon and again on January 11th to provide the state with recommendations for Phase 1B, which, according to the ACIP, will include people who are age 75 years of age and older and frontline essential workers. We expect the guidance for Phase 1B to be available the week of January 18th. Today, we posted a new web page with a little more information about how the advisory group works so that Minnesotans can better understand their role and how the process for determining priority groups in the state will roll out. That web page also includes a form where the public can provide feedback ahead of the next advisory group meeting on January 11th. Agendas and minutes from the meeting will be added to the website by early next week. We just have to get those documents in the right format for posting now that we have the web page to put them on. Going forward, we'll have meeting minutes and agendas posted within a few days of a meeting. Governor Walz ultimately makes the final decisions about COVID-19 vaccine distribution, but he closely follows the advice of the experts on these decisions. And then in concluding, I too want to thank you for your work in helping us share important public health messages during this last year. I never dreamed that we would be talking to you so frequently, but we're all very grateful for the ways that you have helped get messages out. And with that, I'd like to turn it over to Dr. Ruth Linfield.
Thank you very much, Chris. It's understandable that so much attention has been focused on COVID-19 vaccines lately, but we did want to take some time today to talk about some other tools we are using with growing success to fight back against this pandemic and prevent serious illnesses and deaths. One particular tool, a treatment option called monoclonal antibody therapy, has been shown to reduce hospitalization in positive COVID patients if given within 10 days of symptom onset. Monoclonal antibodies are synthetic antibodies that target the virus that causes COVID-19. The FDA has issued emergency use authorization for Eli Lilly's monoclonal antibody therapy, bamlanivimab, and Regeneron's monoclonal antibody combination, casirivimab, combined with imdevimab. HHS began distributing supplies of these drugs to states during the week of November 9th through 17th. MDH is responsible for directing supplies to facilities across the state who are providing these infusions for patients. The state has more than enough supply monoclonal antibodies. Health systems continue to work to open infusion sites. Long-term care facilities have also received doses to provide for their residents. One key point here is that the treatment is effective only if administered to the sick person during the first 10 days of developing symptoms. This means it's important to get tested as soon as possible if you have symptoms. If you wait and get tested later in the illness, this tool cannot help you. If you test positive, especially if you're in a high-risk category for severe COVID-19 illness, please notify your healthcare provider right away after you get the positive test result and discuss the therapy and where you can receive it. In order to have the greatest impact, it should be given as soon as possible. It is given for outpatients, and it is for people who have mild to moderate symptoms. People who are already hospitalized are not eligible for this treatment. The FDA has specified that eligible patients must have certain risk factors, such as diabetes, heart disease, or other conditions that increase their risk of severe COVID-19. We've heard some confusion of this therapy and vaccine. If you test positive and are eligible, those are the criteria for the therapy. The vaccine is a tool that prevents you from getting COVID. It cannot help you if you are already sick with COVID. If you're curious to see whether you may be eligible for this treatment, you can check it out online using the MDH screening tool on the MDH Therapeutic Options for COVID-19 Patients webpage. This is https://www.health.state.mn.us/diseases/coronavirus/HCP/BAMSCEN.pdf. You can also see which facilities have received shipments of monoclonals using the National Infusion Center Association locator. This is linked on the MDH Therapeutics Options for COVID-19 Patients webpage. MDH is working with health systems, the MDH Science Advisory Team, and the Minnesota COVID Ethics Collaborative to create a centralized screening tool both healthcare providers and the public can complete to be referred to an infusion site. Details on how many doses of each therapy, which have been allocated to states, is available on the HHS dashboard. This is found at www.phe.gov/events/COVID-19 without the dash /investigation-dash/pages/default.aspx. A total of 91 Minnesota health systems and long-term care facilities to date have received monoclonals. This includes over 9,500 of the Lilly product and over 2,500 of the Regeneron product. Most of these treatments went to patients who were eligible due to being 65 years of age or older. More information on the drugs and eligibility criteria is available at the MDH website for COVID therapies. Thank you, and I will turn the call back to Mike.
Thanks, Dr. Linfield. Operator, we're ready to take questions.
Thank you. Again, ladies and gentlemen, if you'd like to ask a question, please press star then one on your touchtone telephone. Our first question comes from Catherine Reichert of Minnesota Public. Your line is open.
Sure. I wanted to just ask about why we are seeing some states, I'm just going to use Oklahoma as an example, able to move on to their phase 2 already, while Minnesota is still in phase 1. And then I have a follow-up question to that. We're just seeing across the board, like some states moving ahead much faster than we are.
Chris, would you mind starting with that one?
Sure. Well, we're all receiving vaccine on a pro rata basis based on our state population. I think one thing to keep in mind is that it is based on state population and not healthcare population. So, you know, in Minnesota, we do have probably a larger proportion of healthcare workers because we are a kind of a regional center. So that may have an impact. But all the vaccine that we have received or would have received by the end of this week, 250,000 doses, is not enough to do all of our phase 1A, which is our healthcare workers and our long-term care. So I can only imagine that other states may have either smaller populations in those groups, or they may be moving forward before they've completed vaccinating of all those groups. That's pure speculation, but we're all receiving vaccine on a pro rata basis based on population. So I can't quite explain how they're moving forward unless, and I'll just to clarify, when we talk about phase 1A, even within Minnesota, we have divided that into tiers. So tier 1, 2, and 3. And so we feel that, you know, at this point, tier 1 has been, you know, our regions have received the doses that they need for tier 1. And so we're focusing on, you know, finishing or working on tier 2. It's possible that other states may be using kind of similar terminology and nomenclature that may suggest that they're farther along. But otherwise, no, I don't know how they would be able to do that at this point.
Just a clarifying question too to follow up. When you mentioned that on January 18th, the state should have some additional clarity on that next phase, which I think I understand to include like frontline essential workers, you know, working in retail or grocery stores, that sort of thing. Will the state move ahead into that group simultaneously, or will it be sort of regional? Like in the Twin Cities, if all of like the healthcare workers have been vaccinated first, they can move ahead. Whereas if that's still lagging in other parts of the state, they'll have to get through that first group first, and then they can move ahead. Or would you expect the entire state to sort of move on that next group all at the same time? Does that make sense?
Yes, I think I understand your question. I think a couple of things that we want to have that more granular guidance out that week. We have said that we expect that it'll probably take us through January to get the first doses into all of phase 1A. So I would expect that it would be, you know, starting in February that we could start with phase 1B. And it's really just getting the doses allocated out to the regions for the next round of vaccination. But certainly, you know, if we receive more vaccine than we're expecting, we will definitely move forward. I mean, we have no desire to slow things down, but we do want to have, you know, I guess, a consistent approach. And so if we find that one part of the state has been able to get through, say, all the tiers of phase 1A, then we would not provide them with vaccine and rather redirect that vaccine to other regions where they had not gotten to that point. So in other words, we want to make sure that everyone has a chance to get through phase 1A before we start moving on phase 1B. But having said that, I want to acknowledge that we are doing our best to be as consistent and as equitable as possible, but this is an incredibly messy process. And it seems that every time I turn around, I hear, a situation where, well, how come this person got a dose? I also want to acknowledge that we want to use the vaccine. We don't want to waste vaccine. So, if a healthcare facility is in a situation where they had all their scheduled healthcare workers who are going to get vaccine, and they've just discovered they've got 15 extra doses that are going to expire in 20 minutes. If they pull in anybody they can to use those extra doses so they don't waste them, that's fine. But that can also mean that you hear of some one-off strange stories, and I just want people to be aware of the fact that it's never going to be an exact, perfect process. Okay, thank you.
Thank you. Our next question comes from Glenn Howard of Star Tribune. The line is open.
Thank you. Commissioner, in less than a month, we'll have a new administration in Washington. Apart from money, what is it that you need from the federal government that you're not getting right now?
Well, thanks, Glenn. Certainly money is not a trivial part of the picture. We have significant ongoing needs for financial support to administer this very complicated vaccine program, as Chris has outlined extremely well. So I don't want to underestimate that, but your question is a good one. I think we will also benefit, I hope, from a more kind of cohesive national strategy. We've talked a fair amount on these calls about the limitations of state-by-state approaches, just given the mobility of our population, border communities, legitimate questions that it raises in people's minds about, why is one state doing it differently than another, and is that fair, and how do you correlate the outcomes with the different policy approaches? So I think consistency of strategy would be helpful to the national effort as we see these waves of surges kind of seeming to wash over the country at different times. I think the case has been pretty clearly made that we need more of a nationally coordinated strategy. And I think just sort of message consistency too. So not only the strategy itself, but the kind of the clarity and the consistency of messages coming from different levels of the federal health infrastructure will be very helpful.
Thank you. And diverting a little bit, looking forward to 1B, 1C. Have you guys put together an estimate of how many people are in those groups? And if not, you expect them to be larger than the 500,000 estimated for 1A?
Yes, I think the subsequent waves are significantly larger in number and complexity even. So, Chris, I don't know if you have any more quantitative answer to that.
Yes, we do have those numbers, and in fact, Glenn, they just went through on an email that I will look to pull up. But as the commissioner said, it is much larger. As we look to 1B, it would be, for instance, all adults 75 and older. We know that's about 330,000 in the state. Now, many of them, or a number of them, would be covered through skilled nursing and assisted living, but not all of them. So when you consider that you're adding a number of sectors to that, it will be larger than 1A. So 1B will be larger, as will 1C. But I will try and I'll pull up that information and we'll get it to you.
Thank you.
Thank you. Our next question comes from Mariel Mose of WCCO TV. Your line is open.
Yeah, hi. So I was wondering, how do you simply answer the question that a lot of people have right now, which is, when will I know it's my turn to get vaccinated? Is there going to be some sort of database that will specifically give Minnesotans a timeline of when their phase is going to happen and when they can be prepared for it?
This is Commissioner Malcolm. I'll start, and then Chris, you can add any more detail. It will be different as we go through these different phases, based on kind of how the vaccine is going to be administered. To some extent, if it's going to continue to be based around workplaces, or whether primarily around people's home clinics, or whether there will be stand-up vaccination sites. And the answer is probably all of the above, but what will be available and when will depend kind of on what phase we're in, and there will be a lot of communication through many different forms. There'll be some, an organized communication plan around all of this, heavy use of media, outreach directly through employers and through community groups. But Chris, anything you would add there?
Yeah, no, I concur with all of that. I would just remind folks that we do these media calls on a very regular basis. And so we definitely will, as we are moving ahead and through the phases, we are definitely will be keeping the public informed about that. And then, as the commissioner said, as we move to a new area, we'll use multiple resources to get information out. But I think if you are, well, like I see myself, an average Minnesotan, I don't fall into any of the, certain high risk groups. I'm not in an essential service category. And in my mind, I'm just thinking late spring and summer is when I would be prepared to be vaccinated. I think if people can kind of think like that, that may help with the anticipation and the impatience, is just to realize that for most of us, or many of us, it'll be a number of months before it's time to get vaccinated.
Great, that's good perspective. And then one just quick follow-up. Commissioner Malcolm, you mentioned in the call earlier that case growth is down 60% since the peak in mid-November. Since we are improving on our case count, are you giving Governor Walz that kind of guidance to maybe be able to reduce his restrictions on restaurants and gyms and all that?
Those are ongoing and active conversations, and the governor has said as well how grateful he is to see these improvements in the numbers. We're very happy that trend has been sustained now over a period of weeks, because we've seen kind of shorter cycle ups and downs before. But we do keep also talking about the fact that even with these steep rates of decline, we're still at a pretty high level of viral activity. We're still well above our high risk indicators on some of those measures. So definitely significant improvement, but we're still in a risky situation in terms of how easily these numbers can turn around and go the other way again, just given the amount of virus in the community. So all of that, certainly we look at all of our own data from around the country, as we get more clarity on what mitigation efforts can really help, even when you're in situations where you're being exposed to a little more risk just by the nature of the activity or the setting that you're in. What are the things that can most successfully mitigate that risk, and how strong is that evidence? So all of that continues to evolve. I think the governor will be looking at all the data available right up to the minute that he needs to make his next set of decisions after the current executive order expires.
Great, thank you.
Thank you. Our next question comes from Jennifer Hoff of 11 TV Live.
Yeah, I was just wondering, we know that the state is vaccinating the 1A group, and maybe you talked about it a bit, but how did the first responders who were vaccinated yesterday sort of fall into that group when unless the state was able to tweak some of those sub-priority groups when they fall into 1B, does that sort of affect the supply at all, or public perception on sort of jumping between these groups?
I can take that. Yeah, thanks, Chris.
Yeah. So actually, yeah, that it does create confusion in the public, but let me explain how that happened. In phase 1A, in the first tier, emergency medical services are included. And so, first responders who have that emergency medical services designation, they have certain registrations and certifications. Those are the individuals that would have and should have been receiving vaccine. So it wouldn't and shouldn't be all first responders. It would be only those that are providing medical services. And so I think that the information that was provided about some of the vaccines that were given was accurate in the press release. I think some of the media may not have fully detailed who exactly was receiving the vaccine, but it was intended for only those that were providing emergency medical services and have those specific certifications. And our materials do call out those specific individuals. So it's a crossover because there are some first responders who provide medical services, but we have not moved into phase 1B yet.
Thank you.
Thank you. Our next question comes from Jill Barcom of Star Tribune. The line is open.
Hi, Chris and Dan. I'm joining you late, so I apologize if this has been asked, but we have two state legislators going on national TV basically saying that death certificates have been falsified and implying a COVID death when the causes were something else. What should Minnesotans know about these concerns?
Well, thanks, Jill. I'm going to ask Chris and possibly Ruth as well to comment on that. I think certainly we've heard this allegation before. We've tried to be very clear about the process that we use in Minnesota and relying upon the certifying physicians to determine the cause of death and whether COVID was a cause of death. But Chris or Ruth, either one of you want to start, and then the other can chime in.
Yep, I'll start, and then Ruth, if you want to comment too. I mean, we are following the guidance from the CDC, National Center for Health Statistics. They have a definition for the guidelines that we should be using, and our expectation, and Dr. Linfield could comment on this more, is that all the state health departments are using the same guidelines and case definitions so that we can be consistent in our death statistics. And when we look at, the number of deaths that are reported via this site and what are listed for Minnesota, and there's obviously a bit of a delay in getting that information out, the number that they're reporting is consistent with what we are reporting. So we are absolutely following the national guidance on how we're doing our death reporting from COVID. But Ruth, do you want to comment more too?
The only thing I will add is that the death certificate is generally complete by the funeral home and it's signed by a physician. And yes, we are following the CDC guidance.
So would it be possible to have someone who died from a car accident categorized as dying from COVID?
No, our team does actually evaluate that. And so if someone had tested positive for COVID and then subsequently died, we would review the death certificate, and motor vehicle accident would be the cause of death. And so COVID would not be, they would not be considered a COVID death.
Okay, thank you.
Operator, we have time for one more question.
Thank you. Our final question comes from Brenda Powell of KSTP. Your line is open.
Hi, good morning. There was a question a moment ago regarding the advice that you might give to Governor Walz related to the case numbers, going down. I wonder though, specific to the vaccination, is there anything you can give, of course, moment to moment, day to day, this is changing, but in terms of the vaccinations now, is there any new guidance that you would give to the governor? And if so, what would that look like? Is it sort of X number of people have been vaccinated and that means this? Any guidance in that regard that you're looking at with not cases and deaths, but the vaccinations themselves?
Well, it's an important point. Just the fact that we do now have vaccines in the toolkit is significant. But as we've been saying, it's going to be some months before there's a large enough share of the population vaccinated to really have that change the risk profile, if you will, of how well people are protected against the disease. And as we've talked about, we don't know anything for sure yet about the role of the vaccine in decreasing transmission of the virus. It's about decreasing the progression of the virus into illness, into clinical symptoms. So that we can talk more about that if you want to follow up. But I do think just from a numbers perspective, it's going to be a while before the vaccine picture really changes those public health approaches that you hear all of us keep talking about. Even after vaccination, it's going to be important to maintain social distancing and keep on wearing masks and so forth. Certainly the fact that we're vaccinating healthcare workers, that will be very important and helpful to protecting healthcare capacity. As we talked about in the November surge, a big part of the concern was not just hospital beds, but staff to take care of the people. So certainly those things will increase our capability to manage the pandemic as it continues to be with us.
Can you explain that, Commissioner Malcolm, what you said that you'd be willing to just expand upon in terms of what the vaccine does and does not do yet?
Yeah, and I'd invite Chris or Ruth to comment here too. I think it's a really critical question around the role of the vaccine in preventing transmission or not. Since partly we're looking at, well, what's going to bring these case counts down fastest? At this point in time, it is still behavioral choices that we make, and rather than the vaccine itself to reduce the number of cases, vaccine should help to reduce the number of illnesses. But Ruth or Chris, you want to add something in there?
Well, I'll start by saying that one of the challenges is that what we can say about the vaccine and what they can do is based on the data that were collected during the clinical trials. And because the endpoints that were used for the clinical trials were clinical illness, we can comment and say that, yes, these vaccines are great. And, overall, they have an effectiveness of 95% in preventing clinical illness. We don't have specific information on, asymptomatic illness, which we know exists. And as a result of that, we don't have information on the impact of the vaccine on infectiousness. And so those are things that we will continue to look at and to watch for. It's not to say that they may not, it's just that the data that we have don't give us that information directly, so we can't comment on it specifically. So Ruth, do you want to add to that?
The only thing I'll say just for clarity is that when the studies were set up, they were set up to evaluate for symptomatic disease. So if someone developed symptoms, they were swabbed and the virus was looked for, rather than just swabbing people on a regular basis. So that's why we don't have that information at this time. As Chris said, we hope to learn more, and certainly as we learn more, the public health community will incorporate that into our response.
All right, that is all the time we have for today's call. We do invite any reporters with additional questions to reach out to our communications office the rest of the day. Have a good day, and we will be back with you again soon.
That was today's COVID-19 briefing by state leaders with the Minnesota